Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, everyone, and welcome to another episode of the AAOMPT podcast. My name is Dhinu Jayaseelan, and today we're joined by Drs. Nathan Hudding and Louie Puentedura. Dr. Nathan Hudding is an associate professor at Hahn University of Applied Sciences and Research. He's a part of the research group of Occupation and Health in the Netherlands. He's a member of the Dutch Board of Manual Physiotherapy, and he's a member organization delegate to the Netherlands to AAOMPT. Dr. Puentedura is a clinical professor at Baylor's Doctor of Physical Therapy program, a senior instructor with Evidence in Motion, and a fellow of AAOMPT. Both have published extensively in the orthopedic manual physical therapy realm, but today we'll be discussing their AAOMPT conference presentation titled Integrating Pain Neuroscience Education and Self-Management Support in Musculoskeletal Physical Therapy. Drs. Hudding and Puentedura, thanks so much for joining us.
Thank you. You're welcome.
Thank you for having us.
I'm always interested for understanding how researchers start to do their research. Do you mind starting by kind of talking about how this topic became of interest to you?
Yes, so from my perspective, I'm an orthopedic manual therapist. And of course, I use manual therapy, but I also think that there's more than just manual therapy. So I'm a researcher, but I also work in clinic 1 day a week. So 4 days research and 1 day I see patients. So I think musculoskeletal care is changing and it's much broader than just manual therapy. So I thought, I would like to contribute to enhancing the care for patients, and not only people with musculoskeletal conditions, of course, but also enhancing the care for other people. So that's why I became a researcher and involved in research.
And I guess from my point of view, I'm a little longer in the tooth than you guys, I think. And so I remember the heyday of manual therapy back in the 80s, where, it was very biomechanically, very body-centric model. You found musculoskeletal, issues and treated them right away with, some kind of manual technique, either thrust manipulation or non-thrust. And the results were always, generally always spectacular. But what I found was once I got into the late 80s and early 90s that it didn't always work with all patients. And there were patients that had chronic pain that didn't really get any better. And so I'm a big proponent of spinal manipulative therapy. And, having used it for over 40 years now, I think that it's a very safe and effective intervention for the right patient. And it was that search for the right patient. Who do you do this to? That led me to, want to question what I was doing clinically. And so I moved out of the clinical realm in 2007 when I went into full-time academia. And that's when I started pursuing a post-professional DPT and a PhD. And that sort of led me into the research field. And my interests have really been looking at the safety of thrust joint manipulation, the utilization of thrust joint manipulation, the effectiveness, and so on, and then how it intertwines with pain neuroscience education. The realization that a lot of what we do with our patient isn't just the things that we do; it's also the context in which we provide the intervention. And so I think that's what sort of led Nathan and I to look into this and want to study it more, the integrating of the self-care model and also pain neuroscience with musculoskeletal physical therapy.
And I kind of share a similar background in being a clinician first, and those clinical problems lead to questions that you want to answer as a researcher. But as a clinician, as a researcher, as an educator, all of the concepts keep coming back to how do we get people to manage their problem better by themselves without us as much, maybe. And so this topic that you all are talking about at AAOMPT is really important. And self-management seems to be so intuitive and so integral to the practice of physical therapy, where our general intent seems to be trying to help optimize someone's functional independence. But what are you thinking are some barriers for clinicians facilitating self-management?
Yes, so we recently also conducted some research specifically on this self-management topic, focused on care for people with low back pain. So, in a recent study we conducted, a qualitative study, the major barrier for providing and including self management in the care for people with low back pain were the patient expectations. So, patients do not always expect a self management approach, or they just expect passive treatment, manipulation, mobilization. And we also know that patient expectations are very important with regard to the outcome of a treatment. So, if a patient has different expectations, physical therapists, manual therapists find it very difficult to integrate a self-management approach within their treatment. So that was the biggest the biggest barrier that we found in the research. Besides, of course, also some time constraints. Time is always scarce in treatment. So in the Netherlands, we treat patients half an hour, and then we get the next patient. So time is also a barrier for including a self-management approach, I guess.
That makes a lot of sense to me, actually, because in those early days of manual therapy, if we, the manual therapists, the physical therapists were the ones that did things to our patients to make them better. And we gave them a home exercise program to maintain what we were doing. But it seemed to be a very heavily emphasizing what we were doing to the patient rather than what the patient could do for themselves. And I think it was the rise in the pain epidemic, the realization that we really didn't have a true understanding of how pain actually works. That, now we realize that we need a more biopsychosocial approach. Whereas, early on, it was really pretty much a biomedical approach. So that kind of makes sense. And it's fascinating that, Nathan's mentioned that, one of the barriers is the patient expectations, that when patients come to physical therapy, they're expecting to be made to feel better. Not that they need to do anything to get better, but they're seeing someone so that someone can do something to them and make them feel better. And so it's a big shift now when we're trying to teach people how to look after themselves and manage their problems. So I think this is a great thing.
Yeah, yesterday I talked to someone, and he also compared this with the opioid crisis. People were prescribed opioids for their pain since decades, I guess, and now, we tell them, no, we will not prescribe you opioids anymore. And the same is with the passive treatments. They receive those passive treatments, and now we say, yeah, but we also want to do some other stuff with you, well, self-management, the patient-centered care. We want to have a biopsychosocial approach, etc. So that's patients have to get used to that, I guess.
Yeah, it's not an overnight thing where we've created almost a culture of you go to see the provider, they help you to feel better versus the provider offers you opportunities to make yourself better. So it's definitely a paradigm shift. And so I can completely understand how patient expectations are one of the barriers. And so if we're not on the same page, then there's no way of reading this from the same book to get to the same place. And then in your presentation, you kind of mentioned there's kind of four key elements of patient-centered care. And those four elements were establishing meaningful connections, having shared decision-making, creating self-management support, and then patient-centered communication. And then as I was reflecting on those kind of four elements, I kept coming back to they all mean you have to really develop a relationship with that individual and understand their story before you start to try to treat anything. And in the clinic, something I frequently hear is, especially with people in chronic pain, is you don't know what it's like to be me, or I don't know how to explain what I'm feeling, so your questions don't really make sense to me. We understood the barriers of being maybe time constraints and maybe patient expectations. But what do you think are some strategies to develop a relationship with someone to improve their self-management strategies when we aren't able to really live their experience?
Yeah, so that's a really good question, and of course there are more elements of patient-centered care. But recently we published an article in Musculoskeletal Science and Practice, and we identified those four elements of patient-centered care, and they are all related to each other, I guess. So those meaningful connections, I think that is the most important thing, to start a relationship with the patient, and are really interested in the life of the patient. So not only it is a person with a complaint who wants to get some help from you, but it is a human person. So sincere interest in the person, I think that's a great start of working with your patient. And confidence, trust between each other. I think that's very important, and that costs some time. Of course, it's not in the first treatment. That's not that you have those that sincere relationship with the patient. But I think that's a really good start. And then, of course, I think for self management, that therapeutic alliance, building a strong relationship with the patient is really really very important. So it starts with a relationship with the patient, and of course, then when there is trust between each other, then of course you can facilitate self management. You can use your coaching styles to help the patient and especially to support the patient, because that is very important. And I really like that Kongstedt et al. In the Brazilian Journal of Physiotherapy recently published a paper and give an example of healthcare that's about diagnosis, advice, and treatment, and that is what therapists mainly do. But then we also have symptom management, and that's of actions to reduce the symptoms. So, of course, manual therapists, physiotherapists give some advices to patients to symptom management. Overall, then we have self management, and that's about managing actual or potential impact of the disease, and that's what it's all about. And then, of course, we have self care, and that's what the patient eventually has to do, healthy lifestyle behaviors. So, I think that we are a little bit stuck in the healthcare part and maybe in the symptom management. And we, as physiotherapists, manual therapists, are not really prepared to provide self management support to our patients.
It's interesting. I find it amazing that there are so many parallels between patient care and education these days. After some 15 years of education, I've seen a gradual transition from, the sage on the stage, the professor knows everything, teaching the student, providing all that information in a lecture format, and then giving them an exam and so on. It's changed now, certainly changed a lot more now with, the post-COVID world, where now we're really giving students the tools to do their own learning. They're doing more experiential learning and, finding out for themselves what they need to brush up on, what they need to study, what they understand, what they don't understand. And there's an interesting parallel with how do we manage patients. Years ago, it was, the sage on the stage. The therapist, knew what was wrong, knew how to fix it, and advised the patient on how to not do it again or not have that problem again. And now it's a more patient-centered care. It's more, the guide on the side rather than the sage on the stage. It's, pointing out to the patient that things that they can do to feel better and to manage their own condition so that they can be in charge. Just like students can be in charge of their own learning, patients can be in charge of their own symptoms and their own recovery. And that's a huge transition from the way we used to do it. I think it's for the better as well, but it's something that takes a bit of getting used to.
Yeah, I
Yeah,
think it's all about an autonomous patient. We see getting patient autonomous and also building self-efficacy with patients, and also a healthy lifestyle. I think those are the three important
Hmm.
topics that are very important nowadays.
Yeah.
yeah, and both of those points are excellent. And I again come back to this is a shift in the way we think, and with education and clinical practice, we're really changing the way we're doing both. And with education, I'm actually working on a doctorate now, and I'm learning that adult learners learn very differently than I expected them to, and learning styles, which we've used all the time, there's not actually evidence behind that. And so we've just been doing things out of habit a lot of times, and that's clinical practice too. And so to
Yeah.
be able to change the way we're helping people live their life better, I think that is letting them be the driver and us being more of a passenger versus us being the driver and taking them where we think they need to go. And along that line, I think Dr. Hudding, as part of your presentation, you speak to a difference between self-management and patient education. And maybe this is splitting hairs. I'm not sure. But what do you think are the differences between the two, and why is it important for clinicians and educators and researchers to know the difference between those two?
Yes, a lot of physiotherapists, manual therapists, they think that they provide self-management education. But one of the things that we found was that they not really provide self-management education. They not really focus on those general self-management skills, and they had a very biomedical approach. But also, they also think that if I educate the patient, that's just also self-management support. And when we educate patients, and we give them information, disease-specific information often, how they should behave when they have a flare up or something like that. And self-management support really focusing on teaching general skills that can be generalized and that patients can use to manage their own health conditions independently. So it's not prescribing something or something like that. It's not disease-related education, but it's much broader, more those general skills, how to act on general problems that can occur now, but also can occur in a year or in 2 years. So it's also about this problem-solving skills that are very important for patients, and that's teaching focus on obtaining those problem-solving skills and not only focusing on those technical disease-related skills. And that's the biggest difference between patient education and self-management, I guess.
I always think one of the most important things we can offer is helping a person understand what's going on and potentially why. And I think that leads us right into the understanding of pain. And so there's been this huge evolution in pain neuroscience from a bench research perspective. And we can take that and kind of apply it and integrate it into our clinical practice. And in that way, it seems like pain neuroscience education make a lot of sense for people with musculoskeletal pain. One of the challenges I feel like might exist is we know that when we get too biomedical and we focus too much on the tissue or the science, sometimes individuals can get too far down the wormhole and attach into something that's maybe broken or damaged and not fixed, and it has to be fixed. And so, Dr. Puentedura, I was hoping you can kind of elucidate that and kind of talk to what are some suggestions you have for people that are trying to apply PNE in the clinic without doing the harm that some of these biomedical explanations can sometimes contribute to?
Whoa, okay, that's a great question, and well, we could speak for 2 to 3 weeks on this because there's a lot to cover here. But really, I think some of the things that have come out of pain neuroscience is the realization that the words that we use, the way we describe things to our patient, we have words that can harm and words that can heal, and so that's really changing a lot as we understand how pain works. And one of the things that has frustrated me a lot as a manual therapist, and as someone who got into pain neuroscience very early, and kind of feel like I got on the ground floor in a sense with the pain science revolution, is how it became a dichotomy, or people were saying that it was a dichotomy. You have your pain patients that require pain neuroscience, and it has to be hands off. You can't touch these patients because if you try manual therapy on them or do anything like that, you're basically reinforcing the biomedical approach, and they're the words that harm, right? And then you have your other patients who are not pain patients, just acute injuries and ankle sprain and acute low back pain. They're the ones that a biomedical works really well. I'll go in there and mobilize them, retrain the ankle, manipulate the back, and they recover very quickly. And it's not really a dichotomy; it's more of a spectrum. And, we realize that there are some people who have primarily a biomedical problem, and great, we can treat those biomedically, but it doesn't hurt to sprinkle a little bit of P&E in there to teach them about how pain really works and make pain neuroscience education kind of like, a vaccine against, future chronic pain, kind of protect them in the future by them understanding how pain really works. And then the other end of the spectrum too, those patients who have chronic pain, who have a pain problem rather than a tissue problem, the tissues have, healed after all this time. It doesn't hurt to bring in a bit of manual therapy. It shouldn't be the mainstay of your treatment approach, but it can't hurt to, to move a patient, because the whole point of pain neuroscience education is teaching patients that they can move, they can exercise, that they can do things to manage their pain and go on with their life despite their pain. One of the key things that we need to let patients know is that pain is important. You need to be able to feel pain to live a normal life. And so, a lot of patients who have chronic pain have these unrealistic expectations. They believe that they should have no pain before they start exercising, before they start working, before they start doing anything. And it's just an unrealistic thing that, we need to teach them that pain's a good thing, that pain's a protective measure. And teach them how to manage that pain, but they're not going to start exercising and moving and doing the things they need to do to feel better until they know that they're safe to do that. And what better way to demonstrate safety than to mobilize them, to do things to them, to their spine, to their joints, move their joints and show them that they can be moved and that it actually feels better after being moved, that it actually doesn't hurt like they thought it would. That's kind of like the difference between education and teaching self-efficacy and self-management. You can teach someone how everything works and they know how it works, but they don't do it, right? They need to actually, the rubber needs to meet the road. They need to actually take that education and put it into practice for themselves to actually gain the benefits and feel better. They need to move, they need to exercise, they need to do things that they need to do to get on with their lives so that they can go on with it despite the pain.
To add something is that multimodal care is very important. So of course you can also, in self-management approach, you can also include manual therapy in the symptom management, but also use active approach and focus on those self-management skills. So there is a place for manual therapy, but those multimodal care is very important. And also there's, in every complaint, every condition, there's also always a psychosocial component. Maybe not, it's not the cause of the complaints, but we are humans, we have a psychosocial life, so it's important also to address those psychosocial components, but also not forget to address the biomedical components, of course. So that's very important, huh? Multimodal care and a biopsychosocial approach, I guess.
Yeah, absolutely. I mean, sometimes we forget, we think so much about how pain is complex, but people are so much more complex than that. And I think it's important when we're talking about, PNE or self-management strategies, sometimes we get too focused in on saying that pain is harmful. And in that way, maybe we're making it harmful and we're being harmful to the person by recognizing that, like, hey, you can still have pain and you can live your life, but the stress and anxiety and the depression associated with that needs to be managed and that needs to be uncovered. And we need to give you strategies to make this work in your life. Just looking at some of the evidence for PNE specifically, I just did a quick PubMed search earlier today. There's a couple this year, a couple systematic reviews with meta-analysis saying that PNE can be effective in reducing pain, disability, kinesiophobia, pain catastrophizing. And then depending on the studies, individually, there's small effects or larger effects, probably going to be better when coupled with a multimodal approach with exercise. And that's kind of true for everything. But just like we do for a lot of our interventions, I think we try as researchers, especially, to try to figure out the mechanism behind effectiveness or lack of effectiveness. I'm wondering if either of you have an idea on the mechanisms of how understanding pain can be so helpful.
Well, from the clinical point of view, I think the effectiveness of educating people about pain is the fact that we are first de-educating and then re-educating, because patients that have chronic pain usually come to us with some very faulty beliefs about pain. They believe that pain is very much tied in with the health of their tissues. They think that if they have back pain when they do something, then they're harming the back by doing whatever they're doing. So they stop doing that, and they don't realize that the less they do and they withdraw from activities in society, the less active they become. They become more inactive. They become more disabled. They become more depressed, and they feel more pain, and it becomes this vicious cycle. So teaching people how pain really works and how pain should work as an alarm system, and how sometimes the alarm can be just sensitized and you get false alarms. It's not really a tissue problem at all. Can give those patients the green light to start moving, to start doing things, realizing they're not doing any harm. And I think that's the important part. You mentioned the studies, the systematic reviews that show that pain neuroscience education is effective for all those things. But the important part is that it's much more effective on pain and disability, in other words, function and pain reports, when it's combined with some kind of a movement strategy. Education alone is not effective. There was a famous saying that, education alone is like throwing spaghetti on a brick wall and seeing what sticks. It's not really effective. They have to actually do the things that they need to do to improve their lives. And you can learn about self-help and read all these self-help books, but unless you put it into practice, you're not going to get better. And so this is where I think the pain neuroscience really comes in. The mechanism of pain neuroscience is giving people the security to know that they can move, that they can do things, that they need to get on with their lives. That there are many people walking around with lots of pathologies, lots of tissue problems, but it doesn't bother them. They can just manage it quite well. So why can't they?
So that you kind of touched on it, and I think we all have a bias. The three of us have a bias, but an intervention by itself is typically not effective as multiple interventions put together, because as we think through the biopsychosocial model and the ICF model, people are affected on multiple levels. And so that kind of brings me to my thought about manual therapy as it relates to self-management and PNE. All three of us have done some research in manual therapy and are manual therapists. I use manual therapy every day in clinic, but I also kind of struggle a little bit when I hear, and this is like a never ending battle, it seems like, on social media, and it's never going to go away regardless of how much I try to mute stuff. But we wonder whether manual therapy should be used at all. Putting that part of it aside, when we consider self-management strategies, I think Dr. Hudding, you spoke to this a little bit already, and Dr. Puentedura, you spoke to this as well. But one thought that comes to mind when we think about self-management is integrating activities that don't require somebody else to help. And so where do you think manual therapy kind of fits into this process if you can try your best to take away your bias of its effectiveness in a clinical setting?
I believe that self-management is very broad. And self-management includes also using resources and also creating partnerships and working together with healthcare providers. So I think physiotherapy and manual therapy, that can be part of a self-management approach. But self-management is much broader. So I think that practitioners should also include some problem-solving skills, decision-making skills, action planning, and those kind of topics are very important. But besides that, you can work together with the patients, forming a partnership, and then I think you just can use, if it's in a shared decision-making process, and the patient thinks he could benefit from some manual interventions, and you also think that he could benefit from that intervention. I think that's good to go, but don't make the patient dependent on those interventions. Use it in a multimodal modal approach, and I think that's the place of manual therapy. And of course, manual therapy is broad. It's not about only manipulation and mobilization, but it's also exercises and education. So if you use manual therapy in that broad scope, I think it really fits in the self-management model, I guess.
Yeah, I agree. I think that, some of the social media stuff you're talking about, can be a bit daunting. I think that, this bias against manual therapy or bias towards manual therapy depends on where you're coming from and how you see manual therapy. There are some, I think there are some therapists who don't particularly like manual therapy, who find that it isn't very effective, and it may well be because they're not practicing it as well as they could. They're not doing it the way, with the enthusiasm and the skill and the care that they should. And I think the same thing applies to any other intervention we do in physical therapy. There are some that say manual therapy sucks. Well, I would argue it only sucks if you suck at it. If you suck at manual therapy, then manual therapy will suck. If you suck at exercise, then, exercise will suck. You have to put into it, what you need to get out of it, what you want. And, there are some therapists who are super fantastic at developing great exercises, guiding their patient through exercises and advancing the exercise program, periodization, strengthening. You can get really into it, right deep into the weeds, and absolutely love it. And that's fantastic. And there are some patients who really enjoy that, who get that. Do they become dependent on the therapist that's giving them all those exercises? Well, maybe not as much, because they can continue the exercises on their own, but they still need some guidance to advance the exercises and the expert to tell them how to do the exercises in a stronger or more sort of intense way to get the gains that they want to get. Well, it's the same with manual therapy. A manual therapist can apply the techniques appropriately and effectively and safely, but they don't need to be done forever. And the whole point is that, manual therapy always has exercise right after it, or sometimes even before it, to complement this multimodal approach, if you like. So that's one of the interesting things. I'm going to touch on that in that presentation about, how manual therapy and pain science actually grew out of manual therapy. It emerged from the manual therapy field. And Dr. Chad Cook gave this wonderful presentation for AAOMPT called Manual Therapy and Pain Science, Two Brothers from Another Mother, and how, they really can coexist. And that's, one of the key messages that I hope to make, that they can coexist, that manual therapy can complement exercise and pain neuroscience. But, it really much depends on the patient. There are some patients who like manual therapy, and there are some patients who don't want to have manual therapy. And ultimately, that's the key. You've got to give your patient what is going to work best for them. And and one of the things that will work the best for them is their self-management. And Nathan, I know you're going to say something about that.
Oh yeah, no, yeah. I also want to add that it's also about beliefs, and
Yes.
those beliefs are very important. And if people think they have a worn-out spine or they have stiff joints that are not moving, that's not good. And as manual therapists, we should not say those things. But on the other hand, if we say that they have weak muscles and they have to exercise because they have weak muscles, I think that's also not the truth. So it's not only manual therapy that can induce some incorrect beliefs. It's also exercise, because if you say they have weak muscles and they have to exercise, etc. So it's not only manual therapy. We should educate the patient about the correct beliefs about the health conditions, and I think as well manual therapy, but also exercise should be integrated in our approach, I guess.
Yeah, I completely agree with both of you. Manual therapy by itself can be helpful, but oftentimes is not helpful by itself. Manual therapy applied with harmful words is not going to be helpful. So same thing with exercise. Every intervention that we offer can be good. Every intervention that we offer could theoretically be bad. And so it seems like there's a bias on a clinician to try to fit somebody into their pattern of treatment versus going back to what you were talking about of understanding what's the patient expectations, what's their background, what's their beliefs, and trying to match our treatment to that, knowing that we carry our own expertise as well. And then if we know there's limitations to manual therapy, I also kind of always think about the cons to an intervention. And so we've talked about some of the benefits of understanding self-management. We talked about the benefits and the research behind PNE a fair amount. But we also know that it's not for everybody, not every time. I'm wondering if you both could speak to maybe a couple of the limitations that you perceive, predominant limitations with self-management or PNE in physiotherapy practice.
Yeah, so I think not every size fits all. So I think that uh, one of the cons of self-management could be that clinicians want to use it in every patient. But manual therapy is also not usable in every patient. Exercise is also not usable in every patient. So you should look at some characteristics of patients. Are they open for self-management? Can they understand the concepts? So if they are not open to it, yeah, you just don't have to use a self-management approach because that will not make sense, I guess. So, and on the other hand, it's an individualized approach. So I think it could be that clinician thinks, oh, self-management, I just include this, this, and this, and this, and that's it. But you should really have some shared decision making with the patient and looking to the needs and problems of the patient, and then discuss those things. How can I help you? How can I support you? What kind of skills do you need? But because if you do not do that, I think that's not really. Then you do not optimally use the value of self-management. And I think if clinicians do not use it optimal, I think that could be one of the cons of self-management. So use it on a proper way, I guess.
Yeah, and I think one of the biggest limitations of pain neuroscience and maybe even self-management and self-care models is the patient's readiness for change. They need to be, because we're trying to change behavior, We want to teach them that certain things that they're doing are not really helping them, and they should do less of those things that are less helpful, and more of the things that are actually helpful for them. But they need to be ready to change. They need to be ready to take on that education to understand how pain works. And sometimes patients are not ready for that change. They're not ready to really take on that information and start their own self-management approach. And that can be a big issue. One of the things that I've noted, having used pain neuroscience education for some decades now, is that when patients are not ready for change, they're usually the ones that storm out, and tell you that you're telling them they don't have real pain, that it's all in their head, and and that they don't, you don't believe that they have pain, and they get really angry and ticked off, and storm out of the clinic. But it's usually because they haven't been ready to listen to the information or to hear the information about what's going on with them, and they're not ready to take those steps that they need to take. The cool thing is that later on they might be, and it may be that your intervention, your ability to teach them about pain, has sort of planted the seeds, and several months later, or maybe even weeks later, they may go to a different therapist, hear the same story about pain neuroscience education, and then they get it and they think it's wonderful and it really changes their lives. So, one of the things that we say, Adrian Lowe and I often say, is that, P&E really should be sprinkled in, that it's just, planting seeds that you hope will germinate and the patient will actually flower and, understand how pain works and take ownership of their condition and how to manage it the best way that they can.
I think that's also very important that we as a profession work together and collaborate. Because if that same patient goes to another professional and
Mhm.
there only receives his manipulation, then it does not work. So I think we should work together. We should change our profession, and because then we will get rid of all those inaccurate beliefs, I guess.
I don't know how I don't know how to change that, but that's a good point. We need to
It's
is
a
that
challenge.
there's so much discrepancy in the care that's received, despite so much evidence shifting one way or the other. But that goes into the challenges we have, which is the beauty, I think, of physiotherapy is, or it's a patient centric profession, but then that also means individualized decisions need to be made. And so the generalizability of some of this research becomes a little bit lower. But meeting people when they're ready to change and using it appropriately and not using it for everybody, I think those are huge components of how to be successful when you're in the clinical practice setting, whether it's PNE, self-management strategies, manual therapy, exercise, whatever modalities you're using, whatever it is. I think those things are integral, and I think your discussion is very important in starting that process of change. If you had maybe just last take home point for those maybe that are attending AAOMPT this year or those that didn't make it to AAOMPT this year, what would you want people to know, if you had maybe like a last clinical key point that you wanted them to take away from this?
So maybe I start again, then Ruby can add on me. So I think I have some key messages. I think focus on that therapeutic alliance. That I think that's very important. Use that biopsychosocial approach. So don't forget all the psychosocial stuff. Focus also include those general self-management skills like problem solving, decision making, using resources, etc., etc. And also provide some specific knowledge, skills, and tools because that is important. Assist the patient with obtaining those important tools and skills that he or she will need to manage their condition on their own.
And from my point of view, my key take home message is going to be that pain science and manual therapy can coexist. But it's because we need to move on from this idea that manual therapy is purely a mechanical effect. That when we mobilize or manipulate a joint, we're only having a mechanical effect on the joint. It's much more complex than that. We know that from all the research that's been done about the complex interplay. And there's new information coming out now that maybe when we're using our manual therapy, we're actually restructuring the brain. A inappropriately focused brain that has issues with body parts and laterality, neuroplasticity, all those things are starting to come into it. So it's this concept that, we have shared goals with manual therapy and pain science, and, realizing that the two, can coexist, that you can be a manual therapist who practices pain neuroscience education if you just view manual therapy as different than just a mechanical approach. And you can be a pain science therapist that can occasionally use manual therapy for the same reasons that you can use it in your approach to total management of the patient. But ultimately, you've got to make that mix of interventions that you're giving to your patients appropriate for the patient. And it's a way of sort of doing both a bottom up and a top down approach, so that you get the entire patient involved in the improvement process.
Being open to understanding the patient, being able to match what they need, understanding what they need first, and then understanding that maybe self-management is not for everybody and PNE is not for everybody, but when you do incorporate it, use it with other things, and then that's when it tends to be effective. And so I'm glad that you all have kind of taken the leads in putting this conference presentation together and putting forward all the research you're working through on this. I really appreciate you taking the time to chat about your work, and thanks so much. The listeners, I'm sure, are going to love hearing about it too.
Thank you.
It was a pleasure. Thank you for inviting me.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.